This week we'll also cover gender dysphoria. When we talk about the term gender, we're talking about the public role lived by an individual. It's a term that refers to both psychological and cultural characteristics of one's biologic sex. When you talk about one's biological sex, you're essentially talking about biological indicators assigning someone to be either male or female, or for our child adolescent purposes, boy versus girl. And what is presented in the literature is that it's very much a psychological experience that has social influences as that role is shaped. The process of gender identification begins early in childhood, and between age 1 to 2, children become more aware of the physical differences between boys and girls, or those biological indicators differentiating the assignment of boy versus girl. Then by age 3, children will begin to identify themselves as a boy or as a girl. And by age 4, stable gender identity is established for most children. Again, as we talk about the establishment of that gender role, it's important to keep in mind those sociological factors as well, because it's impacted, that gender role is impacted by peers, family, the media, and other environmental, social, and cultural variables. However, some children don't establish that stable gender identity, and instead will feel incongruence between their natal gender and their own psychological experience of their gender. And those dysphoric feelings can also begin as early as ages 2 to 4. And the clinical problem is not necessarily the child's gender identity, but rather their dysphoric feelings. So identifying and assessing and treating those feelings of dysphoria is the focus of the DSM-5. The cause behind those dysphoric feelings or gender dysphoria is still unknown. When we talk about diagnosing gender dysphoria in children, again, there is a marked incongruence between that child's experienced or expressed gender and their assigned gender, and that must be present for greater than 6 months. There's also 8 criteria within criterion A, and at least 6 of those 8 need to be met. Those include a strong desire to be of the other gender or insistence that one is the other gender. For boys, there may be a strong preference to cross-dress simulating female attire, and conversely, girls may wear only typical masculine clothing and stay away from typically feminine clothing. There tends to be a strong preference for cross-gender roles in make-believe or pretend play. There could be strong preference for toys, games, or activities that are stereotypically used by the other gender. There could be a strong preference for playmates of the other gender. For boys, they may reject typically masculine things, and for girls, they may reject typically feminine toys, games, activities. There could be a strong dislike of one's own sexual anatomy, or even a strong desire for the primary and secondary sex characteristics that match one's experienced gender or the one that they desire to be. Criterion B emphasizes that the condition has to be associated with clinically significant distress or impairment in social, school, or other areas of functioning. And you can utilize a specifier if this is presenting with a disorder of sex development. In the United States specifically, we've seen a recent surge in gender dysphoria presentations and diagnoses. Specific to this graphic, you can see rates of new diagnoses of patients between the ages of 6 to 17, more than double in incidence from the year 2017 to 2021. Here you can see that even when we look at data from individual states, that surge is still significantly reflected. You might be able to find your own state here. We've got California, Massachusetts, Michigan, New York, Pennsylvania, and Washington. Now, some of these states are inclusive of the full range of child and adolescent years of age, so 0 to 17. However, California, Michigan, New York, and Pennsylvania only included data from the ages of 9 to 17. And so I question, had individuals younger than 9 years of age been included, would we see an even further increase in incidence of new diagnoses of gender dysphoria? Diagnostic considerations. Expression of gender dysphoria does vary with age and development, so the criteria is separate for children as opposed to adolescents and adults. It's also important to differentiate other potential diagnoses. For instance, nonconformity to gender roles or transvestic disorder. I want to remind you all that the DSM-5 does specifically focus on the dysphoria symptoms and that dysphoric presentation causing marked distress and impairment in functioning for GD patients. And so that is what sets it apart from simple nonconformity to stereotypical gender roles or transvestic disorder. You should also rule out body dysmorphic disorder and even schizophrenia or other psychotic disorders. Keeping that in mind, though, there are high rates of comorbidities in this GD population, and most often you will see these patients present with high emotionality and also symptoms of behavioral problems. So some of the most commonly comorbid conditions include anxiety disorders, depressive disorders, disruptive and impulse control disorders, high rates with autism spectrum disorder, ADHD, and there are alarmingly high rates of non-suicidal self-harm, as well as suicidal ideation and suicide attempts. So safety assessments and safety risk is important when treating patients with gender dysphoria. There are significant psych mental health nurse practitioner considerations and provider considerations to be kept in mind surrounding treatment of gender dysphoria. And I'm certain that all of you are aware of the multitude of ethical debates surrounding medical interventions in children, adolescents, and young adults with gender dysphoria. Some things, for instance, include the use of synthetic hormones and implications in long-term health outcomes from use of those synthetic hormones. Also, whether or not gender dysphoric patients are favorably completing the required developmental tasks in the given stages of childhood and adolescence in order to ensure success later in life. And also, there is considerable comorbidities, psychiatric disorder comorbidities in this patient population. So whether or not surgical intervention is, or even medical intervention as a whole, is properly indicated is up for debate. Moving to mental health care provisions and PMHMP care specifically, it is critical to establish a therapeutic relationship with these children and adolescents, and remembering that you may be the only supportive environment that they encounter. A thorough psychiatric evaluation will allow for proper diagnosis and also identification of any more appropriate differentials or comorbid conditions. Your medication management should focus on treating problematic symptoms that are presenting and also ensuring adequate treatment of any comorbid conditions identified. Assessing safety risk and implementing safety plans when necessary is key, and ensuring that these patients have functioning support networks and building up that support for them. This is a minority patient population, so it is crucial to maintain culturally competent care with these patients. Ensure that you are maintaining cultural sensitivity and cultural humility in your patient interactions, and try to self-reflect and identify certain points of internal bias that could impede that process. Thank you all for listening to this lecture.